Hi, everyone. Good afternoon. Another Thursday afternoon here. Another Newton-Wellesley Medical Group Lunch and Learn. This being vacation week. Of course, my vacation here, I'm taking it from my kitchen, as you can see. Haven't traveled very far this year, but we'll add it on to all the other things that are different this year. Today, we're really excited about our talk with Dr. Harlan Winter, and Dr. Esther Israel, both from the Inflammatory Bowel Disease Program. And they will be talking about a multidisciplinary management of inflammatory bowel disease in children and adults. A couple of promotion slides before I let them start talking. Next slide, please. Upcoming lunch and learns. We're really excited about our upcoming roster here. We have common skin rashes coming up next week. And then we're really excited about our chair of medicine, Larry Freeman's going to be talking about viral hepatitis 2021. And then we have a nice one about healthy eating for the busy professional and metabolic bone disease. We continue to have our speakers line up. And if you are interested in giving a talk or know someone who has, please contact us. Remember, these talks do qualify for Category 2 credits, and they are all archived on YouTube by searching Newton-Wellesley Medical Group Lunch and Learns. If there's one in particular you missed, I have all the links as well. You're welcome to reach out to me. Next slide. We want to remind people Monday was our opening day at Newton-Wellesley Orthopedic Walk-In. This is our walk-in center for any orthopedic injury, pediatrics and adults. You can see our hours. We are open till 8 p.m. at night during the week and also on Saturday and Sunday. Anyone with an orthopedic injury can just walk in. If you want to call ahead and make an appointment, that's possible as well. We are staffed by our orthopedic physician assistants as well as our Newton-Wellesley Medical Group sports medicine docs. We are there 7 days a week, Monday through Friday, 8 to 8. Next slide. And here's some of the injuries, the orthopedic injuries we'll be managing there. Next slide. I wanted to also remind folks about some of our wellness programs. This one we haven't promoted a while here at Lunch and Learn, which is our Peloton app, which we are giving away 1 year of membership there. It's a monthly charge with the first month. We will reimburse for the next 11 months. If you do start riding or using the app, remember the app, you do not need to have a fancy bike or a treadmill, a Peloton one that is. You can use the app to do anything from yoga, meditation, strength training, walking, running outside, as well as using it for their bike or their treadmill. So please let us know if you want to participate in this program. And also, if you're riding on Peloton, we like folks to ride with our hashtag NWHStrong. We're up to over 90 members with that hashtag, so thanks for that. Next slide. And I'll give over the mic to Dr. Winter and Dr. Israel. Thanks, you guys, for being here.
Great. Can you hear me all right?
Yes, we can.
All right, good. Well, thank you very much for setting this up, and it's a pleasure for Esther and I to talk to you about our pediatric IBD program at Newton-Wellesley. There are currently 5 members of our IBD group. Esther Israel is also the chief of pediatric GI at Newton-Wellesley, and she's going to talk to you about her work with the Improved Care Now network and the parent-patient advisory team, which she started a few years ago and is a very important part of our program. Jeff Biller is one of the clinical pediatric gastroenterologists. Chris Moran has a special interest in genetics in IBD. Jess Kaplan does our clinical trials program, which we have a number of ongoing clinical trials in pediatric and adolescent IBD. To book appointments, there's an 800 number that you can call, 877-PEDI-IBD. That's 877-PEDI-IBD. And you can call that number and leave a message, and someone will get back to you within 1 business day of leaving that message. If it's a more urgent message, you certainly can have one of the 5 of us paged, and we can certainly give you advice about what to do. Heidi Jackson is the nurse on 6 South who coordinates our IBD program at Newton-Wellesley, and I'll tell you a little bit more about the very active program that we have at Newton-Wellesley. Next slide, please. So I'm just going to talk about just briefly about a case that a patient that I saw actually last week, a few weeks ago, was a 14-year-old boy who presented with a 6-month history of weight loss, abdominal pain, and diarrhea. He had a normal hemoglobin, elevated sed rate and CRP, and he had an MR enterography that showed active distal ileitis. His colon looked normal, which is a picture there from his colonoscopy. He had granulomas in his ileum. And after discussing with the parents and with the patient about what therapy to initiate, we decided on oral enteral nutrition, which is a program that we have that Jess Kaplan manages at our program, and it involves taking over 90% of your caloric intake with a liquid diet. This is a therapy that is effective in children, and it's also effective in adults, but adult gastroenterologists rarely use this nutritional therapy. And I wanted to present this patient because I think it illustrates really the value of this. And a lot of our program is centered around our resources at Newton-Wellesley. So he tried enteral nutrition and he couldn't drink it. He just refused to drink it. He said to his parents, "I'd rather die than drink this liquid stuff." But he did agree to to learn how to do NG tube feedings. I must say that most of our patients drink it. He's an exception, but he came into the hospital. He was admitted to Newton-Wellesley last week, and an NG tube was placed on the ward, and he started getting his 2,000 2,500 calorie requirement of nutrition, and he had no abdominal pain, which is typical for patients who have enteral nutritional therapy, as they feel better within a day or two, and this provides motivation for their continuing the therapy. And so he went home from Newton-Wellesley from 6 South. I saw him in clinic this week, and he's gained 6 pounds and has no diarrhea, no vomiting, no abdominal pain, no abdominal complaints, and the NG tube is in place. And Dr. Kaplan's going to see him and follow up and continue this for about 8 weeks or longer if he can do it. This is a program that we've had for a number of years, and I have another patient who lives in Newton who was diagnosed 8 years ago who has never had a medication for Crohn's disease. He went on enteral nutrition and he stayed on a diet, which we'll talk about in a minute. Next slide, please. So the risk factors in terms of dietary issues in IBD, which we're learning a lot more about the role of nutrition and diet as a causative factor in IBD. Breastfeeding seems to be protective. Fast foods and sugar are possible risk factors. Coffee may be protective, although not many of our young patients drink coffee. But processed foods are a big factor in terms of being associated with the development of Crohn's disease, and dietary fiber may be a protective factor as well. Next slide, please. Oops, the next. Okay. So what we've learned in IBD, and I think this is something that this is one area where pediatric IBD has more experience than adult IBD in terms of managing patients especially with Crohn's disease. Not so much with ulcerative colitis, but high dietary intakes of total fats and meat were associated with an increased risk of both Crohn's disease and ulcerative colitis. And there's a nice study by Ashwin at MGH looking at this in a large number of patients. High fiber and fruit intakes were associated with a decreased risk, and vegetables were also associated with a decreased risk of ulcerative colitis. Next slide, please. So meat, especially red meat, processed foods, increase your likelihood of having a relapse with IBD. And we'll talk a little bit about, on my last slide, talks a little bit about the mechanism of potentially why processed foods may be a cause of recurrence and an activating factor in ulcerative colitis and in Crohn's disease. Next slide, please. So this is a slide that looks at dietary emulsifiers, and I think this is important because these dietary emulsifiers are in toothpaste, they're in all kinds of food, they're food stabilizers, and you look at this, you look at this picture, and what this shows is that the green is this film that covers the epithelium. The epithelium is in blue, and you can see that with water, there's a thick layer of mucus and this biofilm on top of the epithelium. When you add substances like carboxymethylcellulose, it doesn't have much of an effect. But when you add polysorbate 80, which is a substance that is used as a food stabilizer, you can see how it dissolves this biofilm and increases the possibility that bacteria can get into the epithelium, where they can activate the immune system. And if you have a genetic predisposition for inflammatory bowel disease, this could then be a trigger for it. So this is an experimental evidence, but there's also this clinical observation that was the basis for doing this experiment that sort of highlights this association. Next slide, please. So the goals for nutritional intervention in patients with Crohn's disease. We always think about nutrition as filling a deficiency. So there are certain nutritional needs that patients with Crohn's disease have, including protein, calories, vitamin D, different minerals. And we look at nutrition as a way to replace these deficiencies in patients who are undernourished from or have malabsorption with inflammatory bowel disease. We also look at nutrition to control symptoms. So if someone has abdominal pain because they're lactose intolerant, that's a way that we can make a dietary regimen to control their symptoms. But this is a new concept in terms of using nutrition as a treatment for IBD, and that's what we did, and that's what we use. That's what we do at Newton-Wellesley. And I must say that the nursing staff on 6 South are experts at taking care of patients with inflammatory bowel disease. They have a lot of experience with it. It's a wonderful unit. They're supportive. They encourage kids to drink nutrition as a treatment, and we're really lucky to have this resource for our IBD program. Next slide, please. So enteral nutrition as a primary therapy for IBD. How effective is it? Well, it's as effective as corticosteroids at inducing remission, but patients must need to take at least 90% of their calories by a liquid diet. It's better than corticosteroids in causing mucosal healing, which is the goal of therapy, and it's a primary recommendation of the ECHO and the Espegan primary therapy group for managing Crohn's. So why consider nutrition as a therapy? Well, many patients don't respond to induction therapy. And if mucosal healing is the target, nutritional therapy is really important in terms of trying to reach that goal. Next slide, please, Esther. I just want to mention, this is the last thing I want to mention. This is a study that was done in Japan, where they looked at looking at a semi-vegetarian diet to prevent relapse of Crohn's disease. Patients were put on Remicade for a year, and they all went on. Half the patients went on to a vegetarian diet. The other went on to a semi-vegetarian diet that included fish and meat. Next slide, please. And after 1 year of Remicade, all the Remicade was stopped, and the patients continued their diet. And you can see that the patients who were on the semi-vegetarian diet had a much higher rate of relapse than patients who were on an omnivorous diet had a much higher rate of relapse than the patients who were on the vegetarian diet. So next slide, please. So I think that when we give patients options for nutritional therapy and IBD, we talk about different diets that are now available: exclusive enteral nutrition diet, which is what our patient went on this last week, Crohn's disease exclusion diet, which is the diet that was championed by Dr. Ariel Levine from Israel, who's giving a talk on the February 28th to our PPAT group. The specific carbohydrate diet, which has been around a long time as an anti-inflammatory diet, vegetarian diets, and Mediterranean diets are all effective in managing Crohn's disease. Next slide, please. I think that's the last one. So with this, I'm going to turn it over to Dr. Israel to talk about our program as well. You have to unmute, Esther.
Thank you, Harlan. I'll say it again. So I'm going to switch gears a little bit, although certainly on a related topic of sort of thinking holistically about inflammatory bowel disease. In the late 1990s, Wagner had proposed this model for improving outcomes in chronic diseases. Inflammatory bowel disease certainly would qualify as such. And what he proposed was that you really need a health system to help prepare the practice team to be prepared for each visit, for each interaction, and to have them be proactive. You need your electronic medical record system, you need your decision support systems, all to be in alignment so that the practice team can proactively manage and be prepared to manage the patients. But that alone doesn't do it. And along with that, you need to have a productive interaction with the patient who ideally would also be informed and proactive and activated. And that comes through educating the patient regarding self-management skills, and particularly in adolescence, as they're sort of learning to become adults and help manage themselves. That's a really important element. And so that's where this quality improvement collaborative called Improve Care Now comes into play. So before we had Epic, before we had a lot of opportunities through our electronic health system, a group of people within the American Academy of Pediatrics decided that working on a quality improvement collaborative in management of patients with IBD would be helpful. And so this is now a national and international quality improvement collaborative with a goal of increasing remission rate of patients with IBD. And it has, as part of its main components and tactics, pre-visit planning, that's where it comes to the prepared practice team, population management, that's the proactive perspective, and patient and parent engagement. Now, we joined Improve Care Now back in 2009 when it was in its infancy. I think we were the 11th group to join. There are now 100 plus care centers in the United States, and as well as in Europe and Qatar and Belgium. And really it cares for 30,000 patients with inflammatory bowel disease. And in that way, it really is the largest pediatric improvement and research community in the world. And so at its basis, it's a registry. And so it provides a registry for everybody, for all of our patients with IBD, but it's a benchmarking ability. It's a community, which really helps us care for our patients ideally with IBD. Presently in our IBD program, we have had within the network 1,200 patients. 600 of them have graduated, but we currently have 600 active MGHFC IBD patients in the collaborative. And this, I'm just giving an example of sort of a monthly report that we get, but basically we have targets. It's like, and this is our performance of our own team, and this is our benchmarking of the rest of the team's performances. And so we look at this on a regular basis and work on improvement projects. So it's not necessarily looking there, there are opportunities obviously with new drugs, and Dr. Kaplan leads our clinical trials group, and we certainly are very involved with that. But in the absence of that, there are also opportunities to improve our patients' care that's not necessarily predicated on a new medication coming around. And so to sort of getting back to the point that Harlan had started with and to this, when we talk about our practice team, we certainly have our providers. Harlan gave you the phone number, 877-PEDI-IBD. You know, at Mass General, we have 20 providers, and many of us see patients with IBD who are not necessarily part of the core IBD team. But as Harlan mentioned, we have 5 members of the core IBD team who are always willing to talk to you and review. And most of us, 4 out of the 5 of us, do see patients at Newton-Wellesley Hospital routinely. And now most of us are remote anyway. So you can always reach us. We have nurse practitioners. The patient that Harlan talked about really probably couldn't be managed ideally without the help of a dietitian. Mental health providers are essential in the management of certainly children and adolescents with IBD. And we actually have just hired a social worker to be an embedded mental health provider within our IBD team half-time. Harlan mentioned Heidi Jackson, who's our nurse coordinator for the IBD program. She's at Newton-Wellesley on 6 South. She coordinates the whole clinic up there, but she also is specifically our IBD coordinator. I don't have her phone number here, but it is 617-243-6404. And she is a great resource. And it's very hard to coordinate 600 patients or more and all of the labs that come in and all of their needs without having a coordinator like that. And then really, most importantly, there are the patient partners and the parents. And Harlan mentioned this PPAT, it's our Patient and Parent Advisory Team. One of the things that being part of this Quality Improvement Collaborative taught us is the importance of patients and parents engagement. We've been extremely fortunate here to have a few parents who created this PPAT along with our guidance. They're a volunteer. They work in partnership with us to build a supportive community. They have educational opportunities for more in-depth learning about all sorts of topics pertaining to advances in care, treatment, and management of IBD. COVID did not even thwart them. Generally, they have meetings monthly, either a social meeting or an educational meeting. They've started a cafe on Sunday mornings once a month where parents, it's a Zoom cafe, but right now the focus is on nutrition because parents have really been very interested in that approach. You know, I mean, for a lot of parents, you know, if it's a choice of lifelong medications and upping the immunosuppressant medications versus nutrition, they would vote for nutrition. It's bringing their kids along sometimes. Sometimes is the challenge. And Harlan mentioned that, for this month's cafe, we have Dr. Ari Levine, who's going to be speaking. And he literally is a world expert on this. Zoom opportunities now allow us to have somebody from Israel speak to people on a Sunday morning at 10 a.m. So it will be a treat for everybody to hear him. And that's all I have to say. I know it doesn't leave us much time for questions, but we're happy to entertain questions, emails, whatever. You can certainly get in touch with Harlan or myself regarding specific patient questions or programmatic issues that you might have. Thank you.
Thank you guys so much. I don't see any questions in the chat box. I did want to ask Harlan, you mentioned that 90% diet, the calories got to come from liquid nutrition. That other 10%, do you give them a specific diet, or you just give them the freedom of what they want to eat on that other 10%? And before I stop, the other thing is, how long do they need to be on that special diet? Is that forever? And that must be a real, to try to get a 17-year-old to follow that. That sounds like an interesting endeavor, that's for sure.
No, it's not. It's not forever. I mean, usually they go into remission after a few weeks, and we continue the diet for between 6 and 8 weeks if we can. And then at 6 or 8 weeks, we start to liberalize the diet to either the Crohn's disease exclusion diet or the specific carbohydrate diet, or another diet that we try to talk to them about trying to avoid processed foods, red meat, try to include more vegetables and fruit in their diet. But it's for a limited period of time. And then we try to maintain the remission with a diet that's more diverse. The 10% of calories, we let the child choose what they want. So lots of the children choose foods that are crunchy, that is because of the texture, but they are free to choose that 10% if they want. Some children decide they're going to just do the drinks and not do any other food. But that's part of the giving them some option and control during that initial induction period of 6 weeks to 6 to 8 weeks, if we can get that.
Great. And then on the diet as well. Go ahead, Esther.
I'm sorry.
No, I just wanted to, please ask the question, John, and then I'll.
I was just going to say, Dr. Norwich wanted to know if you had any thoughts around the ketogenic diet in IBD, sticking along the diet theme.
Well, I mean, a ketogenic diet is really high in fat, and so one of the things we try to avoid in Crohn's disease in particular is animal fat. So that would not, I think that would be challenging to use that diet. Esther, do you have any?
No,
do you see it triggering? Yeah.
Not aware of any data.
Yeah. Is it possible that these kinds of high fat diets we see a lot in the fads trigger more IBD, or have you guys seen that in the literature at all?
No, I'm not aware of anything. No.
No.
I guess the only thing I did want to mention, only because I don't want to give the impression to this group that we don't use medications, because we do use medications as well. But I think nutrition is something that is, I think, more unique to pediatrics than in the adult population. And, so I think it is something that, and because nutrition and growth is so important in pediatrics, that it sometimes serves, as Harlan said, as treatment, and sometimes it's not the sole treatment. It may be, a complementary treatment as well.
Great, thank you so much. So just once again, to reach this great team, you can get them at 877-PEDI-IBD, or as everyone probably knows, any of the pediatric specialists from the Mass General Hospital for Children. You can get it at local Newton-Wellesley number 617-243-6585. That's for any pediatric specialist, and they'd be happy to see you. And Dr. Israel and Dr. Winter have been seeing my patients for many, many years up there in 6th South. So thank you for that, and thanks for coming on today. And I hope everyone enjoyed our edition of Newton-Wellesley Medical Group Lunch and Learn Vacation Week style from my kitchen. And hope everyone has a good weekend, and we'll see you next week. Don't forget, we also have other learning opportunities Wednesday morning with grand rounds with our Department of Medicine and Dr. Friedman. Thank you. Bye.
Have a good day.